following podcast is part of a certified educational activity titled Smoothing the Way in Eosinophilic Esophagitis, Targeted Team-Based Strategies for Pediatric and Adult Care. Access the entire activity and complete the post-test at peerview.com/WSN860. Downloadable slides and practice aids are also available.
Hello, I'm Seema Savis. I am a pediatric allergist from the University of California, San Diego and Rady Children's Hospital. I'd like to welcome you to this unique activity that will explore targeted team-based strategies for the identification and management of eosinophilic esophagitis in both children and adults. Our goals for today and during this presentation, what we'll learn is that the symptoms and presentations of EoE vary between children, adolescents, and adults, and that recognizing these differences can really help with a timely diagnosis and treatment planning for EoE. We'll discuss conventional therapies and how they play an important role in managing EoE, but there can be variability in response and challenges with long-term management that have allowed the support of biologic therapies for selected patients that have EoE. Lastly, we'll touch on the concept of the team-based approach that involves collaboration with patients, caregivers, and healthcare professionals, and how this is essential when we develop personalized treatment plans, including biologic therapies for EoE patients across all age groups. We'll start with the epidemiology of EoE. EoE is an increasing disease that's being more and more recognized, with the majority of patients being children, adolescents, and adults under the age of 50. So clearly, EoE can affect patients of all ages. It's about 3 times more common in males than it is in female. It is more commonly reported in white patients, but it's important to remember that it can affect all races and all sexes, and that access to care could play a role in the diagnosis of EoE. So EoE signs and symptoms vary among children and adults. In infants and children, reflux-like symptoms such as nausea and vomiting are more common. Children also show up with abdominal pain, food refusal, and failure to thrive. Adolescents and adults more commonly present with dysphagia, food impactions, substernal chest pain, and reflux-like symptoms, but that is more rare. Food impaction is actually the most common presentation of EoE in EDs, and it's the most common reason for food impactions in the ER. You can see in this graph from 2004 by Noel and Rothenberg, the EoE presentation really varies by age, with younger children showing up with feeding disorders and vomiting and belly pain, whereas dysphagia and food impactions are seen in older children, clearly in adolescents. Adaptive behaviors can mask how your EoE patient presents. And so it's important to ask the right questions so that you can elicit whether or not your patient is suffering from dysphagia. One mnemonic that you can use is impact. So the I is for imbibing fluid. So these people drink a lot of water or liquid to get the foods to pass down. Modify, for example, cutting the food into small pieces, only taking a smoothie. Prolonged meal times, often the last child at the table. Avoiding harder texture food, so solid food refusal, crunchy food refusal. Chewing excessively, again, taking a long time to finish a meal. Chewing for a very long time is common in EoE patients. And turning away pills and tablets, asking for liquid forms of most medications. So the frequency of atopy is very high in patients that have EoE. In this graph that was done using 705 patients, you can see that allergic rhinitis is very common, occurring in 60% of patients regardless of their age. Asthma is also quite common, occurring in a third to almost half of the patient population, depending if they're children or adults. Atopic dermatitis being very common, especially in younger children less than 11 years old. But even in a quarter of adults. And then IgE-mediated food allergies reported at 76% in children who are less than 11 years of age, and very commonly even in adults and children who are older. So as an allergist, I think we should really consider EoE as part of the atopic march. This is a study by David Hill and Jonathan Spergel, and you can see that EoE falls anywhere into the atopic march because of the range of ages that it can show up with. However, what you do also note is that the presence of IgE-mediated food allergy increases the risk of EoE by about 9-fold. So that is quite a lot. It's also important, as you noted, that there was a lot of patients that have aeroallergen allergies, so allergic rhinitis. Pollens can actually exacerbate EoE, which can be worse during the pollen season, which is shown in the graphs on the left-hand side above and below. And on the right-hand side, what you can see is dust mite antigen stained in red actually depositing into the active EoE esophagus. So again, local exacerbation of the esophageal disease by an aeroallergen. Diagnostic delay is common in EoE, and this is really important. So the time between symptom onset of EoE and diagnosis can range from anywhere from 1 to 3 years in children, but up to 8 years, and the lowest of 3 years in adults. So again, using a study of 705 patients aged 6 months to 65 years, the time gap increased as the patient age increased. So what you can see is that children who are less than 11 years of age have only a 1-year delay in their diagnosis. However, children who are 11 to 17 years of age have a 2-year delay of diagnosis. But if you get to the adult population, 4 years of delay in the diagnosis is common. And again, if somebody walks into your office and they're complaining of these imbibe type of symptoms where they're eating slowly or they're refusing solid foods if it's a child, especially in the presence of being in your office and having food allergies, atopic dermatitis, or other atopic diseases, should really prompt a more thorough investigation for EoE and a more prompt diagnosis to help your patients. So the reason that it matters that you don't want to have a diagnostic delay in EoE is because the longer time goes by without that diagnosis, the likelier it is that somebody will present with an esophageal stricture in place. For example, among adult patients with severe diagnostic delay, 57% of them had food impactions and 52% of them had a stricture in place. Feeding dysfunction, which is especially relevant for children, can also slow down this diagnosis. And you do want to make this diagnosis so that your kids can grow and eat appropriately. 14 to 60% of patients with EoE have a feeding dysfunction, and 21% of EoE patients who are children have feeding disorders and also failure to thrive. So something else to ask about in your patient population. Needless to say, this has a negative impact on quality of life, which has been shown in a number of studies. In 2018, the AGREE guidelines came out, and this is an updated EoE diagnostic algorithm. What you can see is that you first must have a clinical presentation suggestive of EoE. So symptoms of esophageal dysfunction, like dysphagia, like eating too slowly, like refusing foods that are solid. That, of course, will then precipitate an EGD with a biopsy done by the gastroenterologist. We really would like it if people could use a scoring tool that we'll talk about called ERAFS. But at any rate, you need a biopsy of the esophagus, and more than or equal to 15 eosinophils per high power field is absolutely required to evaluate and make that diagnosis of EoE. And again, your suspicion of EoE should increase if you have a patient that has concurrent atopy. Endoscopic features can be rings and furrows, exudates, and frank food impactions. Furrows and exudates are considered inflammatory features and are more commonly seen in children and young adults. However, by the time you get to adults and even adolescents, you can see rings, which is also known as trachealization in that endoscopy report that you might be reading when you're the allergist. Certainly food impactions occur, and you can see in this food impacted esophagus, the rings are very, very clear. The rings and strictures are considered more fibrostenotic features and are more commonly seen in adults. The other thing that's really important to remember, especially in children, is that up to 20 to 30% of patients can actually have a normal appearing esophagus. So getting the biopsy while the endoscopy is being done is really key. So this is the EoE endoscopic reference score, or EREFS, that was developed by Iko Hirano. The E stands for edema, and it is graded as 0, 1, or 2. The R stands for rings or trachealization, the E for exudates, the F for furrows, and the S for strictures. And each of these is graded at the most severe level. So you want to increase the diagnostic yield of EoE, and it's been shown that you want to take at least 3 biopsies from the distal and at least 3 biopsies from the proximal. At the end of the day, the goal is really to get at least 6 biopsies, and you won't miss the diagnosis of EoE, or at least it becomes very unlikely that you're going to miss the diagnosis. And if possible, targeting those lesions that are visible, such as the exudates or an area where there's a furrow, will increase the diagnostic yield. Let's start talking about the therapies that can be utilized for EoE. So you'll remember that after you make that diagnosis, you want to institute a therapy. So one therapy that is commonly used are PPIs. These have both anti-secretory as well as anti-inflammatory mechanisms. They can be a primary therapeutic option. They tend to be easy to administer, but remember that they're systemic, though they do have a long-standing safety profile. Most studies that look at PPIs have been observational, many of them retrospective. Overall, 12 studies note an overall histologic response rate of 42% with PPI therapy. And that is in adults and kids. And about a third of patients who are children will respond to PPI as a monotherapy. This is a study done by Mark Rothenberg's group, and what you can see is that the effect of PPIs goes far beyond an anti-secretory, anti-acid effect, and you can see that multiple biologic processes are changed with the onset of PPI therapy, including things like cytoskeletal organization, mitotic function, and other metabolic pathways. Another way to treat EoE is to utilize an empiric elimination diet. We're looking here at a table that was derived from the American College of Gastroenterology guidelines. Empiric therapy is really the therapy that's noted for elimination diet to be the most helpful. You can do 1 food, 2 food, 4 food, 6 food, elemental formula, and we really don't, unfortunately, recommend allergy-based testing because it doesn't really do a good job compared to just empirically avoiding the foods. So 1 food elimination is efficacious in 35 to 45% of patients. That's milk only or all dairy products. 2 food elimination is all dairy and wheat products eliminated. And that results in a 40 to 45% response. 4 food, milk, egg, soy, wheat is the most commonly used diet when you're using more than just a single therapy. And that's about 40 to 50% effective. And 6 food elimination diet, depending on what you read, 40 to 70%. And that's milk or dairy, egg, wheat, soy, peanuts, tree nuts, fish, and shellfish, all completely eliminated. Elemental formula is highly efficacious, greater than 90%, but it's really highly invasive into a person's diet and is really very rarely used. It's important as allergists that we also remember that food oral immunotherapy can actually induce EoE. It can be as high as 5%, but that's probably the tip of the iceberg, as many patients will stop OIT when they have the onset of abdominal pain or reflux symptoms, rather than going through an endoscopy with a biopsy to prove that they have EoE. It may be more common with egg and milk than with peanut in terms of EoE induced by oral immunotherapy. So it's important to ask whether your patient is on oral immunotherapy for foods when you're assessing for things that might be triggering their EoE. Other therapeutic options include topical steroids. Remission rates can vary depending on the formulation and the delivery vehicle that's used, as well as dependent on the disease severity. So, for example, the fibrostenotic esophagus does not respond well to standard therapies like topical steroids. The nice thing about a topical steroid is, much like an inhaler for asthma, it provides a topical coating to the esophagus. So it doesn't have a lot of systemic adverse events. However, you can get esophageal candidiasis. There are reports of adrenal insufficiency, and decreased linear growth velocity is mostly noted when there's concurrent use of inhaled corticosteroids. Practical options to the use of topical steroids in EoE. There are multiple ways you can use this. There's only one FDA approved, and that's budesonide oral suspension in people 11 years or older. However, the off-label use of a fluticasone inhaler that's puffed and swallowed, budesonide that can be turned into a slurry, or ciclesonide are also being used. There's a phase 3 trial ongoing with a fluticasone oral disintegrating tablet that's compounded as 3 milligrams a day. And this is all relevant to the United States. Budesonide oral suspension is approved in the U.S. for use in patients 11 years and older, was used in a randomized placebo-controlled trial that was randomized 2-1. And you can see in the middle graph here that budesonide oral suspension was far more efficacious than placebo at causing histologic remission, and was also more efficacious than placebo at inducing the remission of dysphagia, which was defined as a 30% reduction or more in the DSQ, or the Dysphagia Symptom Questionnaire. But it's important to remember that EoE pathophysiology demonstrates quite clearly this is a type 2 inflammatory disease. Of course, it's recognized by the infiltration of eosinophils into the esophagus, but this is really driven by a type 2 inflammatory response with the influx of pathogenic effector T cells into the esophagus. And these pathogenic effector T cells make cytokines like IL-4, IL-5, IL-13 that result in the accumulation of eosinophils, as well as causing a decrease in barrier function of the epithelium that then allows the potential penetration of antigens such as foods, milk, egg, wheat, soy. Also, there are genetic predispositions to EoE. When all of this happens, you get this inflammatory response, and the esophagus tries to heal itself, and over time that causes remodeling. Remodeling is defined histologically as well as endoscopically, as well as symptomatically. Remember, this is a clinicopathologic diagnosis, usually with dysphagia and food impactions. And when this happens, the remodeling can feed back and promote the inflammation to be perpetuated. So why would you choose a biologic for EoE? Well, you'd want to consider this in patients who might be refractory or intolerant to other standard of care therapies like PPIs or topical corticosteroids or elimination diet. Remembering that this is a type 2 inflammatory disease, you might want to target the underlying inflammation and the pathoetiology. We'll also talk about multiple forms of atopy and whether you can treat a single person who has multiple atopic diseases with a single therapy. It also has practical benefits. So the only FDA-approved biologic for EoE is dupilumab, which you're all familiar with. It's an anti-IL-4 receptor alpha blocker. It's a biologic. It's an antibody. It's approved in multiple other atopic diseases down to 6 months of age in atopic dermatitis, down to 1 year of age in EoE. It's also, as you know, approved in moderate to severe asthma as add-on therapy, in chronic rhinosinusitis with nasal polyposis, and in eosinophilic COPD, as well as chronic spontaneous urticaria. I note these diseases in particular because these are things that allergists often see. So there have been a couple of randomized placebo-controlled trials in adults and in children in using dupilumab. So what was found was the subcutaneous use of Dupi in adults induced remission in 60% of patients compared to 6.3 in the placebo-treated group. Common adverse events occurring with dupilumab were injection site reactions, which include erythema, pain, swelling, and then the onset of nasopharyngitis. This was a phase 3 kids trial that actually used what was considered a high and low dose. And what you can see is that compared to placebo, high or low dose dupilumab was highly efficacious in causing histologic improvement and remission, endoscopic improvement with visual improvements of the esophagus. And very importantly, it also improved growth parameters in these children. You'll note that there's no symptom output, and that's because it's much harder to gauge symptoms in children than it is in adults. There are a number of other emerging agents for EoE that target the pathophysiology of the disease. These include trials of tezepelumab, etrasimod, IRL 1104 in adults, which is an immunoregulatory MTB protein, Cali-002, which is anti-IL-15, as well as JAK inhibitors, which have been used currently just in case studies. The anti-IL-5 drugs, such as benralizumab and mepolizumab, have been terminated for the use of EoE, as when they were used as monotherapy, they did not induce histologic remission in terms of the T2 inflammation, although they did induce an eosinophilic remission. And larentilimab, an anti-Siglec-8, is also currently not being used in EoE. So remember that EoE is a clinicopathologic diagnosis, and we want to treat to target symptoms, histology, as well as endoscopy. So we want to resolve the symptoms that your patients are having. We want to resolve the eosinophilia and the other histologic abnormalities like the basal zone hyperplasia. And we want to also improve the endoscopic activity, and ideally increase the esophageal diameter. So this is a rather small slide, but I want to bring it up because this is the index of severity for EoE. It's an app that you can find on your phone in the App Store, and it grades all of the severity metrics of EoE, the symptoms, the inflammatory features, as well as the fibrotic features, both histologically and endoscopically. And you might find this to be a useful tool when objectively assessing the severity as well as the response of your patients to whatever therapy you end up choosing to be best for them. So this is an updated approach to treating and managing EoE. This was published in 2025, and it's really targeted towards the adult gastroenterologist, and it was published in the American College of Gastroenterology. However, this is a very useful decision-making algorithm. So the first thing you want to do, of course, is make the diagnosis of EoE, and we went through the AGREE guidelines. And then you want to make the first level choice. Are you going to do a pharmacologic intervention, or are you going to do a diet elimination treatment? Of course, you use shared decision making. You want to decide what it is that your patient wants and can actually do. So if you're going to go down the pharmacologic arm, you're going to choose between a PPI or a topical steroid, and we really recommend doing only one thing at a time. If you're going to do a diet elimination, you're going to use empiric elimination. And again, you're going to talk to your patient and decide if you're going to do a dairy elimination only versus 4-food elimination. Those clinical trials show that either therapy is about equivalently effective. And so choosing what works best for your patient is going to be shared decision making. Once you've instituted that therapy, then you want to assess the response with an endoscopy and a biopsy. Now, what you'll note is at the same time as doing this, you also want to dilate the stricture. So, of course, your gastroenterology colleagues are going to do this. It should be done together with the anti-inflammatory method that you choose to treat your patient. And then you're going to reassess with that endoscopy and biopsy, and you're going to decide whether or not that therapy is working for your patient, and you're going to choose whether you want to escalate or change. Are you going to go to a biologic, or are you going to change or modify your therapy? And again, you're going to assess that response, and then you're going to choose a maintenance therapy that works for your patient. And then you're going to keep them on that because this is a chronic disease. So considerations of using a biologic for first line. Now in asthma, we usually use these all as second line therapies when it comes to biologics. But if you have a patient that has comorbid asthma, atopic dermatitis, chronic rhinosinusitis with nasopolyposis, and those diseases are in the severe enough category to warrant the use of a biologic, dupilumab would be a really good choice for your patient. Additionally, there are also patients who have a strong choice to avoid dietary restriction or swallow topical steroids. So again, shared decision making about an injectable that could be used long-term and every week. So considerations for using dupilumab as step-up therapy include difficult to treat EoE, children with failure to thrive, or patients who aren't growing well, if they need frequent rescue therapies like oral corticosteroids, which we hardly ever use. If the diet restriction is really severe, if they're needing repeated dilations, if they're really severe to treat, they're refractory to other therapies, or they're having adverse events. So it is important to remember that we want to use an interprofessional, multidisciplinary approach to EoE. So your patient in a perfect world is going to see, of course, the gastroenterologist, the allergist immunologist. They're going to work with their PCP. We as physicians like to work with our pathologists, of course, to get their input on what that histology really looks like. A feeding therapist or a dietitian may also be helpful in the care. And of course, your physician extenders like nurse practitioners and physician assistants. The The variety of assessment and treatment approaches is really benefited by this multidisciplinary approach and a conversation between the caregivers. So again, a structured suggested algorithm for follow-up. Again, that endoscopy at 8 to 12 weeks. Decide if there's a response. And if there is a response, then we actually do recommend that patients have surveillance endoscopies, perhaps every 12 to 24 months. And if it's not an endoscopy with a biopsy, it's very important to at least see your patient in the office. Studies now show that loss to follow-up in patients with EoE increases the risk of strictures and food impaction. So really follow up with your patients. Make sure that they're still on their therapy. Make sure that they're still doing well. If they do have a response to therapy, you can have a conversation with the family or the patient about what they'd like to do. Would you like to lower the doses of what you're using? Would you like to introduce more food? And again, all of these types of clinical trials are pending in EoE. And it is really important, again, to have an endoscopy with a biopsy. Sometimes people feel fine, but they've actually lost the histologic and endoscopic response to the therapy that's being utilized. So again, why does follow-up matter? Well, eosinophilic inflammation alone does not explain the full spectrum of symptoms in EoE. Symptom thresholds can vary. For example, sometimes people don't feel anything until that food actually gets stuck and then they need a dilation, but you'd really like to take care of them so that they're not having the onset of a stricture. EoE is chronic and it's relapsing with periods of flare-ups and remission. And the other comorbidities, like we talked about with OIT, are they changing other therapies that could actually influence whether or not their EoE is under good care? Have they moved across the country? Are they exposed to new aero allergens? And so it's really important for follow-up to occur. So when it comes to monitoring biologic therapy, of course, EoE needs to be monitored in any patient after changing any therapy. So you want to make sure that you're really helping your patient. You're improving them clinicopathologically. You want to make sure their symptoms, their endoscopy, and their biopsy improves. With biologics, although symptoms can improve as quickly as 4 weeks after starting therapy with dupilumab, measuring the true efficacy with a repeat EGD and biopsy is recommended at 5 to 6 months after starting dupilumab or anytime you have to adjust the dose. When it comes to topical steroids, repeat endoscopies and biopsies are usually done after 3 months of therapy, and with PPIs or elimination diets, usually about 2 months after therapy. Repeat endoscopies certainly can be done earlier at the physician's discretion depending on the circumstances, for example, if there's a repeat dilation needed. The last thing, if you're a pediatric care provider, to think about is transition of care for your patients and to make a transition of care plan so that you have a goal in mind as your child grows into an adult, so that you can send them to an adult allergist and an adult GI practitioner. So in conclusion, EoE is a chronic disease of increasing incidence and prevalence that affects all age groups and all races and all sexes, and that commonly occurs with atopy. So be sure you ask your atopic patients about any trouble that they have with imbibed symptoms like trouble swallowing or trouble growing. Hopefully this was a helpful module for you to take care of your EoE patients.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals Incorporated and Sanofi. To access all materials for this activity, visit peerview.com/WSN860.